Thank you guys for coming. We are doing, again, our newly diagnosed MS series. It's a weekly lecture from myself. You'll meet Alicia Felicia, our nurse practitioner, if you haven't already interfaced with her. There she is right there. We've got some exciting speakers for you. This is the second time we've done it. The first time was last March, and it was very well received, so we wanted to do it again. Because people get diagnosed with MS all the time. So we can't just have it once, we want to have it the goal is to have it every 6 months and to present different topics. So this time we're excited, we have some financial planning, some legal planning. We're going to get our physical therapy department to come talk about exercise. We'll have Joanne talk to you about counseling and what services she offers. And just kind of get more of that comprehensive care, the stuff that I can't always go over with you in the course of a clinic appointment because we don't always have enough time. So hopefully this will be a kind of a good basic overview of everything. We've got time for questions and everything else, so feel free to interrupt, raise your hand, let me know how else I can expand and help you out. So the first part of the series is just that first question. Someone tells you you have MS, so what's going in your mind? Well, what is it? What's next? What it isn't is also very important to know, and I think that's kind of the goal of the talk that we're going to get through, is just to kind of get a better overview and understanding. How's my volume? Are you guys okay? Okay. All right, so multiple sclerosis, what it is, very basic. This is the most clinical term that we can get to. It's a central nervous system disorder, right? So your nervous system is split up to two things. There's a central nervous system and the peripheral nervous system. What MS is only a disease of your central nervous system. That means your brain, your spinal cord, your brainstem, your optic nerves. What it does not mean is your nerve roots. It does not mean your peripheral nerves. It does not mean your muscles. So there are other processes that can lead to some of the same symptoms. And what our job is to find out, is this a central nervous system problem? Is this a peripheral nervous system problem? Is this a problem somewhere else? The other part of it is, and it's an inflammatory demyelinating disease. So it causes inflammation. It affects the myelin in your nervous system. Other terms, there are courses that you might hear. There's relapsing remitting MS. There is progressive MS. It is present for many years, and it can happen to anyone. And we'll go over all of these in a little bit more detail, but that's just kind of the basic idea. These are the things that you've probably come across the internet. These are things that people have thrown at you. You've heard it. And when I ask people, what is MS, they kind of do the same things. It's an inflammatory demyelinating disorder. It's like, well, what does that actually mean to you? And they're like, I don't know. So that's kind of the purpose of this. From my standpoint, when I find someone who has MS, I'm looking for a few things. Before 1950, there was no criteria for MS. We kind of had an idea of what MS was. We kind of had a constellation of symptoms. It was actually described in the 1800s. So we kind of knew what it was, but we didn't have any diagnostic criteria. So depending on who you went to, they would just say, I think you have MS. And someone else would say, no, you don't have MS. But we couldn't prove it unless we did autopsies. And at autopsy, the misdiagnosis rate was actually pretty high. About half of the people who were diagnosed with MS didn't have it. And then the misdiagnosis rate, people who actually had MS but were never diagnosed, was actually pretty high as well. So in the National MS Society, was started by Sylvia Lawry. Her brother had MS. She put an ad out in the New York Times saying, I don't remember exactly the ad, but it was something along the lines of, need help with MS, please contact me. And the response she got was actually from every other person with MS rather than anyone else. And what she really discovered was that there was just lack of awareness, lack of criteria, lack of support for people with MS. So she created the National MS Society. And from that, she commissioned a researcher, a clinician, to say, well, what is the biggest problem with MS? Lack of uniform diagnostic criteria. And that was first born, the Schumacher criteria for MS. Since then, there's been some developments and some changes, and I won't bore you with the exact details and the evolution, but this is the current diagnosis, and this has kind of stood from back when Charcot described it to more recent terms. And there's two different things that are important. First, we have to know that you've had some kind of damage in two areas. That's the multiple part of multiple sclerosis. So 2 separate areas of the central nervous system, which we call dissemination in space. And it has to have occurred at least 1 month apart, which is dissemination in time. So multiple sclerosis at its very basic is an inflammatory demyelinating disease of the central nervous system that shows dissemination in space and dissemination in time. This is the most important part that a lot of clinicians forget, and a lot of people who aren't familiar with the diagnosis forget. You have to rule out anything else that can cause that. Because if you talk about things that happen multiple times, multiple locations, in neurology, a very simple cause is something like a stroke, which can also occur multiple times in multiple locations. So the most important thing is that you have to make sure there is no better explanation for your symptoms. And then you can say, okay, it is MS. There's a lot of mimics out there. There's a lot of other disease processes that can present with similar symptoms, and that is actually the most important part. MS is the most common chronic disease of the central nervous system in young adults. It is also the most common cause of non-traumatic disability in young people. There's approximately 400,000 cases in the United States. This is up from about 250,000 in 1990. The chances of developing MS are about 1 out of 800 in the general population, and there's about 2.5 million cases worldwide. The highest incidence, of course, is in Caucasians. This is where the typical thought process in the past, if you were a minority, someone would say, well, then you don't have MS. We know that that is not true and that is not the case, but it's still a common teaching, and that's probably has to go with where the disease actually started from. Our world is changing, our world is evolving. We are becoming more global, so it is affecting more people outside of the classic picture. But again, when we talk about where it started and we want to understand the disease, this fact still comes up and still is common. It is a higher incidence in women. It is 3 to 1. Again, this is changing. Traditionally, it was actually thought that it was higher in men. When they actually broke down the numbers, initially the difference was about maybe 2 to 1. More recently, the difference is 3 to 1. So there is something changing about the disease. There's something happening. Why is it affecting women? Why is it affecting white women? Why is it affecting young people? And why is it changing? And how is it changing? What is our influence in what we're doing with that? So that's kind of where all the research and the interest it is. On the flip side, if you have primary progressive MS, and again, I'll go into more details about what all these terms mean, that doesn't show any gender preference. That's 1 to 1, males to females, which is why if a man has MS, we're actually a little bit more worried because it's a higher likelihood that he is primary progressive rather than relapsing remitting. Nothing is an absolute, but we're always just worried about these things. When does it strike? Look at all the patients. So the most common age, 31 to 40, 21 to 30. It does strike in young children, so 11-year-olds, 9-year-olds. It does strike in the elderly population, which is kind of somewhere over here, but 50 to 60s. But the bulk is here. That's why it's the most common cause of non-traumatic disability in young adults. This is the prime of your life. This is when you are finding out who you are, you're developing your careers, you're starting your family. So that's why MS can be such a destructive force. We don't want it to be, and that's why we're here to kind of help educate you that it doesn't have to be. But that's where it actually occurs. What are symptoms of MS that you could present with that would lead you to be diagnosed with MS? It could be anything because it attacks your central nervous system. And this is where we have to sort things out. This is why you need a clinician. This is why we need MRI. This is why we need all our diagnostic testing. Because it can be something as very nonspecific as numbness, tingling, burning, itching, pain. Who hasn't had some numbness, tingling, itching at some point in their life? You can have walking difficulty. It could be just because you're walking slower than you should be. It could be because of some actual weakness. You might not be able to walk just because of balance difficulty. There's definitely bladder symptoms, having to run to the bathroom, having to go right now, having to, when you actually try to sit down and go urinate, not being able to. So that's hesitancy, and then urgency. You can have dizziness, you can have coordination difficulties. Double vision, that's actually pretty more common as an initial symptom. If someone has double vision, it is more likely MS than anything else, whereas some of these other things, we're not quite sure if it is classic. Slurred speech, for sure. And then visual blurring in one eye. What this is kind of pointing to is what we call optic neuritis. And the one eye is important because if you have visual blurring in both eyes at the same time, a bilateral optic neuritis process, we're actually concerned about some other disease process. And again, not all the symptoms are from MS. You could have MS. MS does not protect you from other disease processes, so you could also have something else going on. You might have something else altogether, and that's kind of where we have to kind of work together, and we have strict criteria because we want to make sure we're doing the best thing possible. So kind of getting back to the nervous system in general, what we have here is a neuron. This is the cell body. This is the axon. This is kind of what we call the gray matter, the workhorse of your body. And it sends signals through the axon, which is your nerve, to different places in your body. So if your brain wants to control my mouth to speak, if it wants to control your eyes to move around, your arms, your legs, your sensations, your bowel, your bladder, everything, it kind of does it through this process. So that's what the axon is. The oligodendrocyte is actually the cell that we're most concerned about. That is what wraps around the axons and creates myelin. So the target in MS is actually the myelin, which is formed by oligodendrocytes. And that's kind of the setup that we're here. So axons carry information, and then oligodendrocytes surround the axons, and that's the problem. So when you have messages going down this way, the purpose of the myelin is to allow the messages to be sent quickly and efficiently. And if you affect the myelin, the signals get disrupted, but the actual pathway itself is not interrupted. It's just the insulation that helps things. So a little bit more about it. So here's a schematic picture. What we have that are the white fibers is the axons, and this is an oligodendrocyte, and it starts at arms, and then it wraps around each fiber, and that's the myelin. So this is what it looks like. It's got a nice cell body, and then it just has arms that goes out. So one oligodendrocyte can surround many axons, and that's why affecting it can has such a significant impact. When you have demyelination, so this is what it looks like intact, all the axons, all the myelins, beautiful. And then when you have a demyelination, the wire underneath is exposed. And when that's exposed, it doesn't work as well. If you're a patient of mine and you were newly diagnosed, what we talk about is that your nerves are electrical cords, right? With black insulation around it. Because on the inside is wiring, on the outside is insulation. And should a rat come along and chew on the insulation of the electrical cord, your TV still works, but there's just some sparks. And the signal might cut in and out until you fix it, until you put on some electrical tape. So that's essentially what's actually happening here. It still works, the signal still gets there, it just doesn't get there as well until it gets fixed. This is the inflammation part of it, so the inflammatory. So this is a blood vessel, and what you see around it, all these black cells, those are your immune cells. Those are the lymphocytes that come in and surround and start attacking the myelin. This is the process. So when we say inflammatory, this is what we're talking about. Demyelination was what we just showed on the prior page. That is what multiple sclerosis is. What we do when you first have symptoms, when you see a neurologist, we do a thorough exam. We want to know where your symptoms are. Are there things there that you didn't know existed? Are there clues to let us know where your problems are? We want to look for neurologic signs. We want to know if there's anything else going on, because like I said, you want to rule out other processes. Do you have a rash that now I'm more worried about lupus causing symptoms that are similar to MS? Do you have Sjogren's disease? Do you have more of a peripheral neuropathy process because you have diabetes? And then we're looking for some other reason for your numbness and tingling. And that's what the physical exam allows us to do. We do laboratory studies, autoimmune lab screen, B12, TSH. These are common causes of other neurologic symptoms that look like MS. So we want to know, again, because of that third point, making sure there is no other better explanation. We do MRIs. We rely heavily on MRIs. MRIs were only started in 1980. The misdiagnosis rate of MS significantly decreased once the MRIs were available. And that's actually become a very important process in our diagnostic workup. Before MRIs, we relied heavily on evoked potentials because that was our surrogate marker. After MRIs became available, these become less useful, but we still use them in cases where we're uncertain, in cases you can't have an MRI, because we can't get a good picture of your optic nerve as well. Some people will undergo visual evoked potentials for that reason. Lumbar puncture sometimes lets us know what the inflammation rate is actually occurring, so sometimes we do that. And again, we want to exclude other options prior to telling you that you have this lifelong disease that leads to disability that needs to be committed to a lifelong therapy. So we're very strict because if all of our therapies are safe, no problem. However, they're not, so we want to make sure that we actually know what's wrong with you before we treat you and commit you to lifelong therapy. The MRI in MS, what you'll commonly say is you've got some white spots on your brain, and we'll talk about what that actually is. It's classically around the ventricles. The reason for that is because MS is considered a perivenular inflammatory process, meaning that inflammation around the veins. You have more veins around your ventricles. That's why the lesions tend to occur around your ventricles. When they occur in a certain pattern, they're called Dawson's fingers. James Dawson was a famous pathologist who first described the demyelinating process in multiple sclerosis. It also occurs in the gray matter. This is now becoming something we're learning more that's been recent, probably within the last 10 years, because of our ability to image the gray matter, because of our ability to sample tissue to kind of find out that demyelination also occurs in the gray matter. Again, spinal cord, brainstem, and the MRI can be diagnostic. I look at your picture, you have you look like every other MS patient, and I know you have it, or it can be nonspecific. You've got some white spots, it doesn't look like MS, I really have no idea what it is, so I might opt to watch and wait you to see if it turns into something more concerning. This is the MRI. The way to orient yourself this is the patient tends to be lying on their back, head into the monitor, legs out here. So then this becomes the right side of the body, left side of the body, right side of the body, left side of the body. These are two sequences that we commonly look at. One is called a flare sequence. What that allows us to do is to actually take a beautiful picture of the brain without actually having to do autopsies, so that we can take a snapshot of your brain and see that this is the gray matter, that's the cortex. This is the white matter, that's where all the axons and the tracts are. And these are the ventricles, which is the space where your CSF resides and provides your brain with nutrients. What we see here are these white spots. That's what they're referring to as white matter lesions, because it occurs in the white matter of the brain, lesions of the white matter. They look white because of an imaging property, and then they leave behind a scar tissue. They're periventricular, and when they look like this and they're oriented perpendicularly out like that, they're considered Dawson's fingers. This is another sequence we use. This is a gadolinium enhancing sequence. And what we do, a lot of the times if your doctor or someone will tell you, or you read the MRI report, and they'll be like, there's no evidence of current disease activity. There is no active demyelination. Or there is active demyelination. And what that means is there's now one of these lesions, right? You have lots of lesions, but only a few of them are active. Only one of them are showing current inflammation at the time of the scan, whereas all these other lesions happened at some other time. So MS is a lifelong process. When you have your first symptom, your first event, we know that you've already had spots on your MRI, so there's a lot of asymptomatic disease. Lesions that never caused symptoms and then just kind of stayed there, left their mark, but never caused problems. And then when we happen to capture you in an active symptom, we see active demyelination, active inflammation. And that's the difference between this spot right here versus this spot. some active within 30 days of the MRI scan, sometime before the scan. So it could have happened a month ago, it could have happened 5 years ago, it could have happened 20 years ago. We have no idea unless you've had a prior MRI that shows that the lesion wasn't there. So that's kind of the dissemination in time, dissemination in space. We have to capture you with serial MRIs. MS brain lesions, again, it can also occur in your optic nerve. So this is a histology section. These are your big optic tracts, and you can see that the stain is supposed to be dark for myelin, and here there's a spot that has no myelin. So that's optic neuritis. That's demyelination of the optic nerve. This is the Dawson's finger that we're talking about. So as they come up, they look, I don't know, a radiologist decided that they looked like fingers. So now they've been coined Dawson's fingers after James Dawson. And it's periventricular, again, next to that ventricle. It radiates perpendicular away from the ventricle, and we call them Dawson's fingers. This is actually pretty consistent with MS. We always look for this, which is why when I order an MRI, I always want to look at the sagittal MRI sequence. Depending on where you go in town, sometimes they don't always include it if they don't know what to look for. But this is actually a very important sequence that we want to include. If you are to ever undergo the spinal fluid, the reason why we do a spinal tap to look for the fluid which surrounds your brain and spinal cord. So your brain is very unique. It's the most important organ in your body, despite what any musicians tell you about your heart. Okay, so your brain is the most important organ in your body. It controls who you are. It defines you as a person. And it's involved in every single process of your existence. Because of that, you don't want just whatever's floating in your blood to enter your brain. They have to have special passage. And for that reason, the nutrients and the supply for your brain is special. That's the spinal fluid. So that allows your brain to get the nutrients it needs, the water it needs, the support it needs, and only through very special passageways can things from your blood then enter your brain. For that reason, if we want to know what's going on in your brain and spinal cord, we cannot just check your blood peripherally. Sometimes we need to actually do a spinal tap so that we can look at the fluid that's actually helping your brain to see what's actually there. So that's the reason why sometimes we rely on the spinal tap. It lets us know how inflammatory the process is. Sometimes you have spots in your brain, but there's no really inflammation. We might choose to watch and wait you, especially if you've had reactions to medications before and we're like, well, do we really want to continue making you miserable? You had a question?
When you're checking the spinal fluid, they said there's banding. Is there only so much? What does the banding mean?
We'll show you. So I've got to slide in a couple.
And then it has to be so many in the band?
Yes, there has to be a specific number. So it's an immune activity in your spinal fluid, in your central nervous system. If there's increased white cells, what that actually tells us is there's an infection. So there might be inflammation due to an infection. For MS, there's not an infection. So if we actually see white cells, we're thinking something else is happening. It's not MS, it's something else. If it's lymphocytes, it could be a viral infection. If it's neutrophils, it's a bacterial infection. And that's kind of those numbers that help us decide what's going on. This is the oligoclonal bands. The only way, if you know that oligoclonal bands are elevated or not, is to compare it to your blood. So that unless they draw blood at the same time that they do the lumbar puncture, it is not a good study. The only way we can do this is to compare the bands in your CSF to the bands in your blood, and then we can tell if there's a difference. Because if you have bands, it might be coming from a systemic inflammatory process that then leaks into your spinal fluid, and that's why it's there, rather than a primary CNS process, which is what MS is. Again, we look at the IgG albumin ratio, how much of the proteins there are inflammatory proteins, which is what the IgG is, which is a kind of an antibody, versus just regular proteins. Everyone has albumin. It's the most common protein in your body. So we want to compare if the synthesis of proteins that are inflammatory are higher than just the normal proteins in your body, because everyone's a little bit different. And again, we need to look at your blood at the same time as we look at your spinal fluid. We also want to look at other diseases like infections, and we don't always need it. If your brain looks good enough, your story is consistent enough, then we'll use it. If it's a little bit unclear, if your presentation's a little bit unusual, then we can be very helpful. So it kind of just depends on the person and the patient. This is the oligonucleotide bands. So it's abnormal collections of proteins. It indicates that the immune system is having some kind of activity in the central nervous system. It can be suggestive of MS. Other disease processes can cause increased oligoclonal bands too. It is not a confirmatory test. There is no test to say you have MS. So if we do a spinal tap and they say, I'm going to check to see if you have MS or not, that's not really the proper way to say it. It's, I'm going to see if there's support for MS or not. This is what we look for. So this is the oligoclonal band patterns. What you're looking for is blood and spinal fluid, and you want to compare them. That's why we need to look. So the normal pattern is that there's no bands in either the blood or the spinal fluid. This is what we commonly see if the study's done and you'd have some other process, is that there's bands in both the serum and the spinal fluid, so that it's not increased in one compartment for the other, so therefore it's probably not from a primary central nervous system process. This again is the identical pattern. What we're looking for is then a monoclonal protein. There's just one protein there. So oligoclonal bands, oligo means multiple, so multiple bands rather than a single band. This is what we see in MS. So blood, nothing. Spinal fluid, multiple bands. The number we look for is actually 4. So if you have more than 4 bands, then it is more consistent with MS. It is not diagnostic of MS. And this could also be something that we see, but it's a little bit unclear, is that you have bands in both places, there's just more in the spinal fluid. And again, the number that we're looking for is greater than 4. If we kind of switch to what MS is and kind of the disease process, you'll hear of these different terms. There's relapsing remitting, there's secondary progressive, there's primary progressive, and progressive relapsing. What essentially it means is this process, that you're fine, you're doing well, you have an attack, that's what this bump is. It lasts for a few days to weeks, and then it recovers. And when it recovers, you go back to being completely normal. You're fine for a certain amount of time, and then you have another attack. Dissemination in space, dissemination in time. So if you have the same attack in the same place, it doesn't meet dissemination in space, it only meets dissemination in time. If here you had optic neuritis and here you had arm weakness, now you've had dissemination in space and dissemination in time. So that's kind of what we're looking at. So first event, second event, at a different place, that meets diagnostic criteria for multiple sclerosis. And again, you go back to normal. This is the disease course of attacks, relapses, stability, nothing. Attacks, relapses, 100% recovery, going back to baseline, over and over again. Sometimes you don't recover 100%. The attack was so bad that then you're left with some residual deficit or disability, but you're still flat between attacks. And then you have another attack and you're not getting complete recovery either. This is a more aggressive course. Most patients fall into this category, 80% of MS patients actually. From this, 50 to 60% become secondary progressive. So the difference between this and this is that shift in that baseline. Between attacks, you're accumulating disability. So it's not flat. It's not back to normal. It's still being disabled between attacks, worsened by attacks, but during attacks, you're still slowly getting worse. Primary progressive, of which there's about 10% of patients, total MS patients fall to this, is from the very beginning. They don't have attacks, they don't have relapses, but just continuous decline. This is the rarest form, progressive relapsing. That's about 1% of the population. Decline from the beginning, punctuated by those same relapses and attacks. Decline, punctuated by attacks and relapses. What is an exacerbation? Those bumps, those flares. It goes by different names. Exacerbations, attacks, relapses, bouts, flares. It's all the same thing. Some active inflammation on your central nervous system. We define it because, again, sometimes you have pseudo-exacerbations, you have other attacks, you have other things going on. And for MS, again, we want it to be clear-cut that it's MS and not any other process. So we say that you need to have the symptoms, worsening of your current symptoms, or new symptoms, but it should last at least 48 hours. Because if it's shorter than that, it's probably a stroke, it's something else. We're not quite sure what's going on. But if it lasts for more than 48 hours, and it's not due to something else, fever, infection, stroke, other things else, then it's probably a relapse, but we're never sure. It may or may not correlate with MRI enhancing lesions, depending on when you get steroids, depending on how good of an enhancing study it is. And we're not always sure if you actually had a true exacerbation or a true relapse. So if we kind of talk about MS in general and that relapse, we'll talk about exactly what's happening here. So this is your immune cell, this is a T cell, all right? It's floating around your body, it's surveying, it's kind of trying to figure out what's happening. It takes care of you, it prevents you from having infections and other processes, right? So it's attacking a virus and a bacteria here. But every now and then you'll get some bad T cells. Those are the autoimmune cells. So these T cells help protect you. Every now and then, they decide to start attacking your own body. And when it attacks your own body, you have an autoimmune disease, which is what MS is. What triggers these cells to become the bad cells? We're not quite sure. There's some genetic factor. You have to have some genetic change. There should be some trigger, some bacteria or infection that causes it, and then some environmental cause, be it smoking, salt, vitamin D, something like that, something in the environment. You kind of need to have all three factors in place. And when you have all three factors in place, then your autoimmune cells gets turned on, and then it turns on and attacks the myelin. So this is the bad T cell. It's walking in your blood. This is the blood-brain barrier. And here is your brain space. So blood space, brain-blood barrier, brain space. It's walking along. There's an attachment point, which then allows it to shoot out kind of grease, I guess if you'll say, which allows it to slip through the brain-blood barrier. So like I said, we don't want anything floating through. It has to have very specific attachments, points, and other things so that it actually gets into the brain space. Once it gets into the brain space, it causes problems, and again, the target is the myelin. So this is the neuron, the axon picture that we showed earlier, and the myelin here are these blue things around the axon. So here's the myelin, here's the T cell. It has been primed to attack the myelin. It calls on some of its buddies, some B cells, some helper T cells, macrophages, which then starts attacking the myelin. And when it attacks on the myelin, there's some dysfunction. The signals don't get sent there. It doesn't actually get broken, but the signal gets disrupted. And then over time, oligodendrocytes, that cell that promotes myelin, then comes in and remyelinates. This is what your body does beautifully on its own. We just need to give it help. Right? So it remyelinates, it kind of heals the process. And that's the process that we're trying to help. We're trying to prevent those immune attacks. We're trying to promote this remyelination step. Overall in MS, if you don't get treated, the natural history of MS before we had therapies available, back in the 1950s, back in the times of Charcot in the 1800s, most patients develop some disability within 10 years of their diagnosis. More recently, in an age where we have better therapies, better supportive care, better symptomatic treatment, better disease-modifying treatment, most people actually do well. And that's the difference, because we have therapy, we can diagnose you early, we can intervene. If you don't get treated, you can probably still walk at 25 years, but we don't really know who's going to be one of those bad people and one of those good people. So yeah, we overtreat, but I think we overtreat with good reason, because like I said, 50 to 60% of people who have relapsing remitting MS become secondary progressive, which is a huge number. And we want to prevent that. 10 to 20% do have benign MS, benign being a not great word, but we don't have a better word for it. I tend to prefer mild MS. And those people, they're in their 80s, they've had MS for 30 years, and you probably wouldn't know it because they actually do pretty well. But how do I know that you're benign? I only know it 30 years later when you've been okay. I do not know it when I first diagnose you because I unfortunately do not have a crystal ball, despite my really trying hard for it. I just can't get that magic ball yet. But since I can't have it, then I do overtreat because I want to take care of people. General health is just as important with MS. So we want to make sure that you get immunized, you don't get the flu, you don't get other diseases that can make you feel worse. We want to make sure that you get checked for age-specific cancer regimens. We want you to exercise because we want you to stay healthy, stay fit. We know it's very important for your MS. We want to make sure you don't have hypertension, diabetes. We don't want you to continue smoking because those are all cardiovascular risk factors, things that lead to other neurologic diseases and conditions, heart conditions, that will make your MS worse. Because again, MS doesn't protect you from everything else. It's just something else you have on top of everything else. If it's good for your heart, it's good for your brain. So everybody understands what a heart-healthy diet is. It's also good for your brain. Just stick to that rule. If you're pregnant in MS, it actually shows that it actually is good overall. Patients who are pregnant and have MS have fewer attacks during pregnancy. There's no major issues in actually getting pregnant. It doesn't impact the pregnancy itself, carrying the pregnancy, delivery, no really problems there. There does seem to be some attacks again within the first 6 months after pregnancy. So the pregnancy state is protective. We think it's hormonal related, but we don't quite know. But once that pregnancy state is off, then your MS comes back. During pregnancy, we try to avoid MRIs. We think MRIs are safe. There's no studies to prove that it's unsafe because it's mostly magnets, it's not radiation, but we try to avoid it if we can. The gadolinium is something we try to avoid in pregnancy because, again, if it crosses into the placenta, we don't really want it to affect the growing fetus. So we can try to do it without GAD if we can. Sometimes we just need to know what's actually going on, though. So it kind of just depends. How bad are you? How sure are we what's happening? Do we need to make sure something else is not the process? We try to avoid MS medications. Most of them are category C. So pregnancy categories in general come in A, B, C, D, and X. A means it's actually safe in humans. There are very few medications that are A. I can't even think of one. But we don't actually go out of our way to prove that a medication is safe in humans. So we don't really have very many A drugs. B drugs means it's safe in animals. C means we don't really know. We don't know if it's safe or we don't know if it's harmful. There's just not enough data. D means it's a little bit harmful in animals, maybe harmful in humans, but if the benefit outweighs the risk, it's still okay to use. X means it actually causes birth defects. Most of our MS drugs are category C drugs because we don't have enough information. In fact, most drugs overall are C drugs. Most of actually the drugs we give pregnant women are C drugs. So there is some, again, if the benefit outweighs the risk, we try it. But in MS, we want to give you the best chance possible. So if you don't need medication because we know pregnancy itself protects you, we try to get you off the medication. If you have aggressive MS, you may still have attacks during pregnancy, and in that case, we might want to keep you on the B category drug, which is actually glutathione acetate, like the only drug that carries the B category rating. Smoking in MS. This is kind of a study that they did. There's 2 lines. This is the non-smokers. These are the smokers. On this line is time. So time to conversion of clinically definite MS. So like I said, the first attack, right? First attack, first symptom, you don't have MS yet. You have to have 2 attacks before you have MS. And then this is the risk of developing MS over time. And what you see is a striking difference. You have a higher risk of developing MS earlier, getting that second attack, if you smoke than you don't. Not that just because you're not a smoker doesn't mean you're getting it, but if you smoke, you're making your MS worse. So we're actually pretty hard on people who smoke, and we go out of our way to tell you to quit smoking, and we go out of our way to try to help you quit smoking because we know how bad it actually is. The other thing that this graph doesn't show is smokers have more relapses, and if you smoke, your medications don't work as well. So there is an interplay there. We don't quite know what it is, but we know that it's important enough that we counsel patients to stop. If we're going to talk about why we treat and the disease-modifying therapies in MS, this is the overall arching goal. We want to reduce the number of attacks. If you're going to have an attack, because again, these therapies aren't cures, if you're going to have an attack, at least have the attack be less severe. We want the MRI to not have as much disease activity, because again, you can have asymptomatic attacks, which we see on MRI, but you don't actually have a symptom on. So that's actually a surrogate marker for your disease. And we think it actually affects disability. We actually know that it affects disability. One of the most interesting drugs, the beta-seron, has been out since 1993. We've had over 20 years of follow-up for these patients. And the way clinical trials are designed is that half of the patients get the drug, the other half don't. And then when the study ends, the people who never got the drug then are allowed to be on the drugs. So from the initial studies on beta-seron, which was over 20 years, actually 21 years, they compared the group who got the treatment first versus the people who got treatment 2 years later. In just a 2-year delay, the people who got the treatments 2 years later never caught up to the people who got the treatment first. And the people who got the treatment first are less disabled 20 years later than the people with a 2-year delay in treatment. So it's actually very important that we treat early, and we know that it actually impacts disability. We also know that how many attacks you have in that first couple years will then indicate how risky your MS is. So again, this is the disability status scale of 6, which requires a cane to walk, a walker to walk, some kind of assistance. Your ambulation is impaired. And this is time from onset of MS. So 10 years from MS, 20 years, 30 years. And you can see that people who have multiple attacks, greater than 5 in 2 years, reach that disability much higher, much sooner than if someone had less relapses. So again, decreasing the number of attacks becomes important, which is why we treat.
Did you say 5 in 2 years?
What do you mean? Oh, greater than 5 attacks in 2 years means you have a higher chance of becoming disabled earlier on. Relapses lead to long-term residual disability. Again, we know the number of relapses are important. This is the change in EDSS score before relapse into after relapse. And the more relapses you have, these are the number of patients, the more relapses, the more disability patients get. And that's kind of what this chart shows. So this is the natural history of MS. So we call these arrows our MRI activity. This is what we call a clinical threshold. So like we said, if you have an MRI attack, it doesn't always lead to clinical symptoms. We think it has to be a big enough attack in a certain spot before you actually have symptoms. So when it crosses these lines, these are clinical attacks. These are radiologic attacks. This line is the disability line, and this is the natural progression. So clinically isolated syndrome, you have MRI activity, but now you finally have one event that crossed that clinical threshold. When we take a picture of your brain, we see prior MRI lesions. So that's kind of what we assume that this occurred here. And until you have your second clinical attack, then you finally, or what we call relapsing remitting MS. If you continue to have clinical attacks and MRI changes, about 5 to 15 years later, you have secondary progressive MS, because as we say, the disability line changes. And the disability line here, again, crosses the clinical threshold. If you happen to get an MRI before you have any symptoms, but you may be someone who then progresses to MS, we call this asymptomatic MS, or what we call the radiologically isolated syndrome. My mentor actually studied this, and I actually think it's a very fascinating disease. I think our answers to why some people progress or not is going to be in studying this population. So who are these people? People who have headaches, people who are research subjects, people who bump their head on for whatever reason and get an MRI. And then we take a picture and we're like, you look like you have MS. Have you ever had a symptom? And they're like, no. And we're like, oh, okay, well, where are you in this picture? We know they exist. So that's kind of where the radiologically isolated syndrome. But this is the natural history of MS. If we give you treatments and we can decrease those MRI activity, right? So just decrease the number of MRI changes you have, we can then decrease the amount of disability you have. And our hope and our goal is to completely eliminate the secondary progressive stage of MS. So that if you're here, you had 1 or 2 attacks, you've had a couple MRI changes, but you never become secondarily progressive MS, never become permanently disabled, I'm happy. You're happy. Everybody's happy. You're still working. You're still contributing to society. You're still growing and building your family. You're there for your kids. You're there for your grandkids. Everybody's happy overall. It's a very good place to be. That's why we treat. That's the rationale for treatment. That's why we're pretty aggressive about it. That's why when you come in and you're not on disease-modifying therapy, I'll actually spend some extra time lecturing you why I want you on therapy. And we try to do this. Now, we overtreat for sure. Like I said, 50 to 60% progress because of this. There are some people who might be okay not treating. so that if you've been on therapy for 10 to 20 years, you haven't had any other attacks, and you're really miserable from your therapy, I might take you off just to see how you're doing, because you might be one of these benign people. But I just didn't know when you were first diagnosed. I only know that with hindsight. I don't know that up ahead of time. Disease-modifying therapies in MS, there are 10, 11 approved now, depending on how you want to split the counting. There are the interferons. There is glutathione acetate, copolymer, Copaxone. This has been reformulated to become less frequent. There is a reformulation of interferons, which just got approved, which instead of taking once a week, you now take once every 2 weeks. There's IV infusions, which is what Tysabri is, once every 4 weeks. There's Gilenya. These three are oral pills. These are injections. Gilenya once a day, Aubagio once a day, and Tecfidera twice a day. So these are all the currently available therapies. 1993, 1996, 2005, 2010, 2012, 2013. All recent, all in the last 20 or so years. When you have an MS flare or an MS attack, we usually treat it with IV steroids. You can use oral steroids if we use it in the equivalent dosing. If you're in a rural location, I can't get you to an infusion center. If you don't have insurance, oral pills are significantly cheaper than IV steroids. The effect is the same, so we can sometimes opt for that. But we tend to use it for a functional deficit because steroids kind of have side effects. They don't make people feel very good. They can disrupt your sleep. They can upset your stomach. So we want to use it when there is actually a functional deficit, because most likely if we had never given you steroids, you would have just recovered on your own anyways. But we want to accelerate that time. So what steroids do is it doesn't affect your ultimate level of recovery. It just shortens the time to recovery. So if it's just numbness and tingling and you're going to recover anyways, and it's not interfering with your work, we might not want to treat you that and subject you to the risk of steroids. If you can't walk, we might want to give you steroids because that's a longer time of not being able to get back to work. If you cannot see, it's very important we give you steroids so that we can shorten that attack so that you can get back to work as soon as possible. So again, functional deficit, especially if you don't tolerate steroids well, because if we use it long-term risk, you have a risk of osteoporosis, you have a risk of fractures. We affect your system so much that we don't want to do that. So steroids are great as long as they're used appropriately. It's definitely not a long-term answer. We've tried it. We've done trials doing IV pulse steroids. It doesn't work. Steroid risk, again, this is what we already talked about, increases your blood sugar, especially as you age. You're going to have more risk of diabetes. We don't want to add to that. Osteoporosis, avascular necrosis of the hips and shoulders. It causes cataracts. In the short term, it causes behavioral changes, weight gain, increased risk of infections if we use it daily. So what it isn't. Here are some common myths. We're going to shift now. What it isn't, it was not due to saccharin. You did not drink a Diet Coke in your 20s and cause your MS. There are some studies out there. Those aren't reputable sites. It's probably not the environmental trigger we're looking at. Stop blaming yourself. Because of the therapies, because MS has changed, it does not mean that as soon as you're diagnosed with MS, you're going to be in a wheelchair. That's what we're trying to prevent. It doesn't mean I can always prevent it, but that's still always my goal. And I think I've had enough success that I can say it does not always mean that. Again, it's not your 40-year-old white female. We know it affects all races, all ages, both sexes. It affects everybody. Pregnancy is actually okay. We recommend it if you want it, so you don't have to worry about that. There's really no risk of passing it on to your kids. It does run in some families, but I think the risk is small enough that I think the fear of passing it on to your kids actually is unwarranted. Breastfeeding is okay. And we actually love exercise. We think it's so beneficial. There was a time period when MS patients were told not to do any physical activity because it worsens their MS. Those are people who do not understand the pathophysiology of MS, because MS patients have heat intolerance. They told you to avoid exercise, which is the worst, absolute worst thing. What I would tell you to do is just change your exercise, right? So you might not be able to run the marathon, but you can still sprint, you know? You can still do yoga, you can do water aerobics, you can ride a bike, you can do other activities that are just as helpful, you just have to change it. There's no cure for it, despite what anyone's trying to sell you. There is no cure for MS. I would love for there to be a cure, there just isn't. Anything that's promised right now is probably just a way to take your money. Save your money for that trip that's really important, save your money for something that's really fantastic that you really want to do, but don't save it on any promise of cures. And the reason why there's no cures, this is how complex the immune system is. This is how complex the immune system as it relates to MS is. There are all these cells that are involved. There's a complicated interplay. And if we affect one cell, we can positively affect one pathway and we can negatively affect another pathway. And we actually don't know what we're doing sometimes, but we've got some good therapy. This is why sometimes when we do experiments in rats and animals, it looks really good, but when we apply it to humans, it doesn't work because the human is so complex and so complicated. A lot of studies, unfortunately, will show some sort of benefit in rats and they immediately apply it to humans, which is not the right way to go because we want to do a careful study to prove that it actually works because this is such a complex interplay. There is light at the end of the tunnel, all right? So what's next? What are we talking about in MS? How can MS affect your daily life? What are the future research directions? All right. MS patients, because of their disability, they're more likely to stop working compared to healthy people. We want to affect that. What you actually have to do is to understand workplace protections, understand what you're actually entitled to, understand that MS fits under the Americans with Disability Act. You have FMLA, you have these protections so that we can maintain your employment for as long as possible. Just because you have MS doesn't mean you can't be employed. We just want to work with you to find the right job. You might not be able to do the job you really want to do, but you can still do something. You just have to reapply yourself. We have to figure out what it is that you're passionate about that you can still do. Most jobs allow you to work from home. Some jobs allow you to take breaks. And if you can do that work, great, you know. And we want to work with you to try to get you to do that. If you can't walk anymore, you can still work in front of a computer. You know, there's different things we can do, and there's different ways to apply yourself. And we want to continue to be productivity, but you still have protections. This is actually why one of the talks we're going to have is to talk about some of these issues, some of the legal implications of MS. Marriage, unfortunately, 24 years after diagnosis, only 33% of patients are still in relationships with their partner. It causes a lot of stress between partners because one person who's disabled or feeling bad or feeling sick and the other person either doesn't understand or they try to help too much and the person who has MS is like, you know, you're making me feel disabled, you're making it worse. There's other things that are there. We know caregiver support is very important. That's why actually we have Joanne Fairchild, because what she offers is not only patient counseling, but she offers family counseling. Because we know these issues are there. We know you want to be there for each other. How do you bridge that? How do you begin those open dialogues so that then that support becomes productive and then we can avoid this issue? This is kind of sad though. Of healthy controls, only 50% are still married. So there's just overall, maybe you just picked a bad partner to begin with. For MS patients, if you had with onset before 6, having children was actually protective. So again, we want you to have kids. We think we want you to contribute to society. We want you to contribute to our future generations. You should have kids. I think people feel better when they kind of see what they're doing. You don't have to have kids. You know, if you're anti-kids, you can be anti-kids, but it's okay to have kids. Again, caregivers. 50% of really severely disabled patients have anxiety, are depressed, have backache, have tiredness. They worry about their own health because it's tough to care for someone in that role and not take care of yourself. And sometimes you just feel you can't bring it up, you don't want to hurt them, or you bring up too much, you're pushing them too hard, and then you're getting frustrated yourself. There's all sorts of interplays and interactions. We kind of want to sort it out. 36% of relatives report their careers were affected by the illness of their family member. FMLA also works with partners. So if your family member gets sick and you need to take time off from work so you can take care of them, then you have protections for that as well. 7% gave up their jobs, 5% turned down a promotion because of their MS. Financial consequences of MS, 37% report overall standard of living has declined. They lost employment. They've had to spend more money on disability. 46% of men versus 26% of women reported financial problems due to MS. 50% of patients don't take vacations due to financial difficulties. So please, don't waste your money on a cure. Save it for that vacation that's actually going to be much more therapeutic. And then we kind of want to do things that are that help you. If you recognize that this is going to be there, you can always plan for it. It's when you don't recognize it, you don't plan for it, that it affects you the most. And we can avoid all this. How do we avoid all this? Well, we kind of decide what we kind of want to do. The reason why we are set up the way we are, because if we treat you in an outpatient setting for a relapse, you let me know you're having a symptom, I bring you in so that you can see my nurse practitioner, Felicia. We can do an MRI in the outpatient setting. We can do IV steroids in the outpatient setting. The cost is so much cheaper than if you're hospitalized in an ER and become admitted. If we can save your pocketbook from that standpoint, we're actually contributing to you. Avoiding using steroids unnecessarily. Avoiding other treatments or therapies that may or may not work, because we want to protect your financial future. MS, the care model that we know is the most important, is to treat the disease activity, to treat the symptoms, because all of this affects the disease, affects your quality of life, affects your depression, affects your ability to go to work and other things that may not actually have to do with an acute flare or attack. We want to look at personal psychosocial stress levels, grief, employment, social isolation, financials, and we want to take care of your family. If we take care of all of this in a comprehensive MS model, you're actually better off. And that's what we strive for here. The future of MS, that's actually very interesting. We want a better biomarker, right? The MRI only tells us so much. I still want better ideas of who's going to be that person who responds well to this therapy. They're not going to respond to this therapy early on. I need to put them on this medication right now. I need to tell them what their risks and benefits are. I can tell you right away, I want that magic 8-ball, right? That's what the biomarkers will help tell me. We want to know about this radiologically isolated syndrome, these asymptomatic MS. I think they actually hold the future and the promise. There are progressive disease therapies directed to that secondary progression. That's actually the focus of research. We've got some promising data in early initial trials, so hopefully we'll get there. And remyelination strategies. How do we repair better and faster? That's actually in early clinical trials as well. So as MS today is a much different disease than it was 20 years ago, because we have all these disease-modifying therapies, it will be different 10 to 20 years again into the future, because we'll have some of these answers. We'll understand MS better, we'll be able to do that, and we might get as close to a cure as possible. Do I think we'll ever have a cure? No, but I think we can pretty much eliminate progressive disease and actually make it so that it becomes a non-issue. So this is kind of a short little video of what remyelination can do. Hopefully it'll work.
Remyelination involves forming new myelin around axons, can restore axonal signaling and neurological function, and may reestablish protection to axons and
axons,
lost as a
myelin.
result of demyelination. Remyelinating an axon requires several steps. First, there must be a sufficient number of oligodendrocyte precursor cells at the injury sites. The oligodendrocyte precursor cells must then differentiate into mature oligodendrocytes that have the capacity to myelinate axons. In MS lesions, oligodendrocyte differentiation and remyelination are often inadequate or incomplete. There is much evidence indicating that inhibitors present in the MS lesion block oligodendrocyte precursor cell differentiation and remyelination of demyelinated axons. Therefore, finding ways to block these inhibitors to promote oligodendrocyte precursor cell differentiation and the repair of demyelinated axons is being pursued by many laboratories. This has led Biogen IDEC to investigate LINGO-1 as an inhibitor of oligodendrocyte precursor cell differentiation. In vitro and animal studies demonstrate that blocking the LINGO-1 pathway can promote oligodendrocyte precursor cell differentiation, myelination, and remyelination. LINGO-1 was discovered at Biogen IDEC and stands for leucine-rich repeat.
There'll be a quiz on that later. I want you guys to remember all of that.
Interacting protein. LINGO-1 is a transmembrane protein. Inhibition of LINGO-1.
But this is the most intriguing part. So the difference between not treating and treatment, you can see all the sprouting of those arms that we're talking about to make remyelination actually occur.
We observed rat oligodendrocyte differentiation over a time span of 6 days in the
But drastically different.
movie or presence, right movie, of a LINGO-1 inhibitory antibody. Blocking LINGO-1 activity results in increased differentiation, as shown in the change in appearance of the cells on the right. In a mouse model of MS, little to no remyelination is
So these are the
seen
axons.
on the left.
There's nothing around it.
That LINGO-1 expressed on axons inhibits remyelination by blocking interaction of axons with oligodendrocytes. To test this, LINGO-1
And then once you apply the antibody, suddenly those areas have now been remyelinated. There's the myelin now in areas that were previously attacked, healing, quicker recovery, less disability.
fibers.
All right, and that's what I have. Any questions? Sure.
Is there a correlation? So you talked about beta, and I assume you were saying interferon, having the 20-year data. So with all the new medications that are out, are there any long-term benefits for things that haven't been out as long?
Oh, probably. We can't prove it yet. So we think that it probably does. Beta-serin has the benefit of being the first medication to be approved, so it was studied in the 1990s, so we have 20-year data. The earliest data on like Gilenya figolimide, which is the oral therapy, was only out in 2000, like maybe 7 or so we don't have that 20-year data. So I think we will have it in 20 years, we just don't have it now. We think it works, it'll do the same thing and it will be beneficial.
So from a patient standpoint, there's no greater benefit to taking something like beta interferon over some of the oral medications that you think?
So it depends on the patient. So whether or not the medications, I think there's a right medication for every single patient. So some patients can be on the interferons and do very well. Some patients can be on glatiramer acetate and do very well. Some patients can do very well on the oral therapies. I think there are people who don't do well in each of those categories. I think the most common reason why people don't do well is because they don't tolerate the medication, right? So with the interferons, you get a lot of flu-like symptoms, which leads to non-compliance, which means you're not taking the medication, and the medication is definitely not going to work if you don't take it. You get needle fatigue from some of the injectables. Some of the oral therapies have effects on your white blood cells. Some of them affect your liver. So those might not be the right medications either. Some of the oral therapies cause significant GI issues. Some of them might cause a risk of birth defects. And because MS affects females in their childbearing years, it might limit those medications. If you fail any of those medications, then I'll step you up to the most aggressive therapy, which is natalizumab or Tysabri. Hopefully soon we'll have another therapy that fits along that class that can be an alternative to natalizumab. The clinical trials for those therapies, so Lemtrada or alemtuzumab, ocrelizumab look very good. They're just not quite yet ready to be approved. And so we'll have a medication for everywhere you are on the spectrum. Mild disease, aggressive disease, severe disease. If you like needles, hate oral medications. If you hate needles but are okay with oral medications, or you just want, like, once, alemtuzumab is like once a year dosing. So it kind of just depends on who you are and what your factors are.
Are the outcomes the same, basically? Like, if you take Copaxone versus interferon, is there one more effective than the other? Not worrying about how you tolerate them, but is there one that's more effective?
No.
The studies don't, the studies use different endpoints, so it's hard to compare one study.
They do use it. They use different endpoints, and you're right. It is actually very hard. There is no comparative study showing that one medication is superior to the other. The way we measure studies is what we look at is the main primary outcome tends to be the annualized relapse rates. What we take are MS patients who are highly active, right? So they've had 2 or 3 relapses a year, because if you've only had 1 relapse in 5 years and the clinical trial only lasts 2 years, I can't prove that it's effective. Right, so we're taking a very specific population, people who have had 2 relapses in the past year, put them in the clinical trial, and then compare to see if one drug or the other. So there's a whole lot of statistics involved with that, and there's a power and there's sample sizing. To do a proper comparative study showing that one medication is superior to the other requires thousands of patients. And we just don't have the money, the funding, or the desire, or the ability to do that study in any real way. I don't think we're going to have very great comparative data. There were early comparative data between glatiramer, acetate, and interferons. There were early comparative data between the different interferons, and those actually all showed similar efficacy. There really isn't comparative data between the orals and the injectables, and between the Tysabri. We have clinical experience. We know what we look for. We think we have a good idea on what's a better, more effective medication, but we don't always know. And again, it depends on who you are in that MS. Are you someone who is going to be more aggressive early on, or are you going to be mild, and you would have done fine on any of the more mild medications anyways? I don't know, and I can't tell. Usually we decide about what's the right medication for you, given patient factors, and then I start narrowing it down based on what happens. So if you start one medication and you have relapses and attacks, that's not the right medication. We need to switch. You start one medication, you have side effects, you have reactions, we need to switch. Once we switch, then we check out another drug and we see how we do. So yes, we want to treat you as early as possible, but we also want to treat you in the right way, because you're going to have a lifelong disease. You're going to be on these medications for a very long time, and we know that emotional well-being is very important. So we want to make you happy. We don't want to make you miserable. I don't want you to be one of these patients who tells me you hate your weekends because you're injecting once a week and you have flu-like symptoms, so you dread every single weekend. I would hate to be the reason why you're hating your weekend. You should enjoy your weekends. That's your one day of breaking. So again, it just kind of depends on who you are and what's going on. If you hate needles and injecting every single day just makes you miserable, we should do something else. I've actually had patients tell me that they don't want another pill because they just have to be on so many pills. So they'd actually rather be on injections because it's just a different mechanism of what you're doing, right? You're injecting instead of having to swallow another pill. I have some people who are so needle phobic that I mention it and they're like, so they stop listening to me. So it depends on the person. The only cases that are different are the people who I feel, based on some markers, disease activity, I think they need to be on natalizumab right away, then I'll do that. But for everyone else, it just it's a patient preference up to a certain point. It's the right medication, it's the right side effect for you up to a certain point. And then it's a trial and error. We just kind of work together to decide what's the best medication. The reason why I want you guys to take a big part in it and decide is because, again, if you don't take the medication, if I just force the medication upon you, the higher chance are that you're not going to take it, you're not going to listen to me, and then you're also not going to tell me that you're not taking it. So then what ends up happening, and we know these from studies, is that patients got escalated pretty quickly, and it had nothing to do with the fact that they actually failed the medication. It was just because they didn't like it, they didn't take it, and they didn't tell their doctor they weren't taking it. So we want to make sure we're doing the right things, and that's kind of where the individualization is important. I think maybe like 10 years ago when we only had 5 therapies, those questions were more important. Now that we've got so many therapies available, we just kind of figure out what's the right medication for you.
Thank you.
Okay.
I have one other question. I know the interferons, the Copaxones, all of those, they help block your antibodies from attacking. But are there any other things that you can do to increase that remyelinization, like to speed it up? Yeah, but is there like another drug that does that too, or a food, or anything? How do you increase?
Well, no, it's a little bit of everything. So like I said, that's why there's that picture of that complex thing. So your immune system is part of it, right? So what I commonly use is that electrocord analogy, and I use the rats, right? If you're trying to heal, and you're, so in that analogy, your electrical cord is your nerve, the insulation is the myelin, and you use electrical tape as remyelination. Well, you can't remyelinate effectively if you're distracted. You can't remyelinate effectively if you're depressed. You can't remyelinate effectively if you're not feeling healthy. So the things you can do, the things that are powerful, eating a healthy diet, exercising, doing all the things, because if you feel better, your body's inflammation is decreased, which means your body can heal better. Those are the things you can actually do to help your body heal better. The drugs help. They're all essentially cages for the rats. They don't help that healing process. The only thing that helps that healing process is to not stress the system. And you don't stress the system by focusing on things like making sure your depression is well treated, making sure you're ensuring for financial stability, making sure that your resources and you're connected in your community and that you know where to get things. A lot of the times when you get first diagnosed with MS, you're the only person in your entire circle that has this disease, and no one else knows what's going on. So actually opening up that circle so that you have a support system so you know where to go should you have questions becomes very important. That's the purpose of this. That's the purpose of us getting Joanne Fairchild here. That's the purpose of us actually getting Robert here, who's going to be our patient services coordinator. So that's actually a new position that we've created, and it's kind of to help connect patients to resources in their community. It's the reason why we work with the National MS Society. It's the reason why we raise awareness. It's why we get more money so that we can continue doing these researches, so that we can get better strategies. We're not there yet, but I think we'll get there.
What about stress? How much does just having a super crazy work and family and life affect the disease?
It depends on what the stress does for you. Some people find stress motivating. So if I told them to stop working, that would actually lead to more depression than anything else. Your body can only do so much at once. So if you're trying to be the person you used to be, right? You have MS, you have some disability, you used to run marathons and you can't because you have left foot drop, then there's some realities you have to face. There's some things you have to change, right? So if you're someone who used to do so many things at once, can you still be that superwoman? Probably not. But you can still do a lot of things. So it's just changing the disease activity. I think stress is pretty maladaptive, meaning there are very few people who actually thrive on it. Most people, stress increases your cortisol levels, increases the underlying inflammation in your body, and actually makes things worse. So chronic stress leads to chronic pain, leads to chronic fatigue, leads to depression. So people who are chronically stressed, little aches and pains hurt worse than someone who's not stressed. They are more depressed and they can't sleep as well. So yeah, stress is definitely bad. We want to find a good balance. We want to decrease things. We want to do it in a way that's simple and easy. It's very easy to say eliminate stress from your life. It's actually hard to do it. So there's got to be ways to do it. And there's got to be things we can adjust and change. Any other questions?
I have a question if somebody else is going to ask. I'm trying to give other people a chance.
Sorry, we're really new with this.
No, that's fine.
Two questions. One is the heat intolerance that you talked about, is that benign? Does it make any difference in the progression of the disease?
No, it doesn't make anything in terms of disease progression. What the heat intolerance is, the way your nerves work is that it sends signals. When you have a demyelinated area, the signals don't get sent as well. And if you're in a perfectly normal situation, slowed conduction doesn't matter, right? If you're just sitting there and the signals get there eventually, it's not that big of a deal. The problem is if you're trying to do things and be really quick, and then the signals don't get there, that it becomes a problem. Well, the problem with heat is that it increases that signal. So it's trying to send the signals really fast through a congested network. So that's where the heat intolerance comes. So what you're trying to do when you raise your body temperature is then you suddenly can't walk or you can't weak because your symptoms come back out. Is it harmful? No, you're not causing a relapse. You're not causing your symptoms to be worse, but if you relax and calm down, then you'll be better. Is it harmful because it might be depressing? It might cause your anxiety and stress? Yes. So it kind of depends on what it's actually causing, what it's doing for you.
And the other one is there any correlation with the number of lesions on the MRI? So you do a study, you see the number of lesions. Is there any correlation with the number of lesions at the time of diagnosis with long-term prognosis?
No, there actually isn't. And that's kind of the most frustrating things. It's what we call the clinical radiological paradox. So I have patients who have 1 or 2 lesions and they are disabled. I've got patients who their brain is actually littered with lesions and they're fine. You can't tell that there's anything wrong with them. There's a strong clinical radiological paradox. We don't quite understand why it is. We're trying to understand that better. That's where the research comes in. One of my research interests is actually advanced MRI metrics. So how can we better define this? Because our MRIs are great, but they're not perfect. They're not a perfect biomarker, and there's processes that go on that we don't understand. So we need better biomarkers. We need a better understanding of that process. But there's a clear clinical radiological paradox, meaning that your MRI scans do not really define your actual disability progression. Some of it's location. So more spinal cord lesion probably does have a bigger impact on disability, but number of brain lesions, not so much. Yep.
Back to the remyelinization part. Is there anything you can do on top of the therapies?
On top of the therapies. Not at this time. We think, so there are 2 drugs in development now, and there's many more on the way. I think in the future we can. Just right now, there's probably nothing. And your body remyelinates. Your body does do it on its own.
Because I had heard initially that like once a nerve cell's messed up, you can't fix it, and yeah. It is
So
what it is.
a nerve cell, sure. A neuron, for sure. Your oligodendrocytes are different. Your oligodendrocytes have precursor cells that are there. Lots of things cause demyelination. And your oligodendrocytes actually you have oligodendrocyte precursor cells, which are cells that are just waiting so your body does remyelinate. It does it on its own. It's just how well it remyelinates, how well it heals, we don't know, and we can't tell, and that's the process that we're trying to help. Okay. So.
Because of seizures is how we get the diagnosis. Why MS has seizures, or how seizures affect MS? I mean, I understand that not all, just little percent of people with MS has seizures.
About 10%. So the reason why they have seizures is what we consider cortical irritation. So it's too much electrical signal. So the way it should go is your neurons in the gray matter create electrical signal, it sends it down the axon and it goes somewhere else. Sometimes it goes into kind of this weird feedback loop. That's what a seizure is. So this electrical signal that instead of going where it should go, it just kind of feeds back upon itself, and then it causes a symptom, and it causes either a big seizure or a little seizure depending on what it is, but it's what we call essentially cortical irritation. So it depends on where those lesions are. If those lesions are what we consider juxtacortical, which is right next to cortex, it can then irritate that part. Now seizures are interesting overall. Everybody can seize, right? Given the right circumstances, given the right situations, we can all, if I drink enough and suddenly stop drinking, I'll seize. Some people, if you hit your head, you'll have a seizure. So everyone has a certain threshold at which they seize. Some people just have a higher threshold than others. So there's 2 peaks where people seize. One is when you're young, and kids who have fevers can have seizures just because it causes that rewiring circuitry, but it doesn't actually become a problem. So that's why when we have febrile seizures, if you ever had kids, or when as a kid, if you had a febrile seizure, we don't think a big deal of it, but it can happen because it's just the right conditions. The other one is like in the elderly population. So some people suddenly they're in their like 70s and 80s and they suddenly start having seizures. Well, it's probably because they had some stroke, some cortical irritation, and now they have an infection or something else that disrupted their system. MS is the same way. It's a threshold. So some people present as seizures as their first symptom or event, and we treat it just like everything else. We treat your MS and we treat your seizures, just like any other symptom, just like if you were to have numbness and tingling, just like if you had weakness, we'd send you to physical therapy, just like if your lesion caused a depression, we would treat your depression. So we treat the symptom, which is the seizure, and we treat the MS. Okay.
I think it took a couple different therapies, but I think the one I'm on now, I've kind of, at least for now, stopped having
The attacks.
Yeah.
Mm-hmm.
But how can I tell? Like my feet are numb, but you get used to it.
Right.
So it's hard to tell if it's getting worse, staying the same, maybe not as bad some days. It's kind of hard to tell if my balance is worse, if it's, how can I put it into some kind of a parameter where I can know if
Or you
other
just think
things
you're
are
crazy.
doing? Yeah.
No, it's It's hard. It's definitely hard. So we do different metrics. That's why we see you. That's why when you come to the clinic, we time you. We do the 9-hole peg test, because these are little objective measures that helps. How do you know you're not, I mean, I think, and how do you sort the common question, well, how do I know I'm just not getting older? You know, how do I know it's just not too much stress?
How do I know it's not
You don't.
something else, like,
You don't, but we follow it with the best surrogate markers that we can. So we do MRIs if you have new attacks, if you have new lesions, because we know that that's going to be the best marker of disease activity. If you don't have disease activity, but you've had MS for 20 years, are you not feeling good because you've now entered more secondary progressive stage? I don't think we know. We usually know if someone's secondary progressive because they've been doing it for like 5 years, and we're like, oh, okay, you're secondary progressive because you've been getting worse for the past 5 years. If MS patients fluctuate daily, so you have good days and you have bad days, and that's just common.
when it's hot, it's a little
Right.
worse.
When it's hot, it's a little bit
It's not
worse.
as bad.
When you're happy, when you're on vacation, you're a little bit better. When you're down, you're
When
not.
my kids are in school, it's
Right,
a little better.
right. So what you know is your daily fluctuations, right?
Okay.
No one is going to know your MS better than you, right? You've lived with it, you've embraced certain things, you know what's good, you know what's bad, you've embraced it, you know what it is. You know what your good days are, you know what your bad days are. So when it's different than that, when other people who know you really well suddenly start making comments, then you get checked out. Developing a relationship with your neurologist so that we can know you. And one of the things I don't like is our fractured healthcare system. So you see a doctor for 1 to 2 years, you go see someone else for 1 to 2 years, no one really knows who you are, so I can't really tell how bad you're doing because no one's following you. But if we actually can get back to that, then you will actually have better answers. In which case, then I kind of leave it back to this. So it's you know your disease the best. You might not know it right away, but you can know it later.
And you know what, when your kids get to a certain age, they'll tell you when you're doing well.
Tell me everything.
I know, I have a 15-year-old that tells me all the time, like, Mom, what's going on right now?
Yeah.
You know, when I'm having double vision. I never realized when you have double vision that your eyes go
Yeah.
kind of crazy. And he says, Mom, what's going on? He said, maybe you need to rest because your eyes are just one eyeball over
Right.
here, one eyeball. I never knew that
Yeah.
except you told me last. I never knew that your eyes like kind of flurry over like that. No
Yeah.
one had ever told me. Even my ex-husband never told me. He probably saw it. He just probably.
You probably saw it, he just didn't want to upset you, so he didn't say anything.
But you know what? When you have a child, they'll tell you, won't they, in a minute.
They'll tell you, and they'll give. So I think there's other things, but you know your disease and you know what's going on. If you've done everything, right, you have no stress. You're one of these fortunate people who have no stress in your life. You're one of these, you have no infection, it's not the summer, you're happy, you're retired, money's not an issue, and all these things. And then you're noticing that it works, then yeah, we might. But I think outside of that, it's so hard. That's kind of where the focus on research is actually important. So if you have the means, you have the funds, support the research so that if we get better biomarkers, we get better understanding of the disease, we can answer that question. We just can't do it today.
Okay. And my other question was, if it's something that's a muscle weakness,
Mhm.
I know your muscles are kind of controlled by the nerves.
Right.
Yada, yada, but, okay, like two winters ago, I was skiing.
Mhm.
Last winter, I was having trouble. This winter, I'm kind of afraid.
Mhm.
So, well, maybe this is the physical therapy.
Physical
section
therapy.
Part of it,
Yeah.
but like, you know, how much can you get back?
You can get back a lot.
If it's,
You can retrain a lot, and you can adapt. So
it's
can you get back, I don't know what the triple, I don't ski, but I guess there's like triple, if you were doing like the really bad, go back to bunny slopes and then build your way up, you know? Do something easier, do something simpler. There are probably gonna be some limitations. If you have significant balance issues, we probably don't want you to be unsafe because if you get on your skis and then now you break a hip or hurt your knee, then it's worse. But can we change your activities? Can you still do something that's fun? You know, if you go then to cross-country skiing, something that's less, I think the scariest thing is to go down a hill, so. I can't, but you know, can we change
Well,
it?
it used to be fun, but
Yeah.
now it's scary. So
Yeah.
that's-
And part of it's just mortality. I mean, I used to rock climb, and now I won't. There's nothing wrong with me. I don't have MS, but I just am afraid of doing it because I know what happens if I fall. So there part of it is just getting over that fear yourself. So part of it's that. Part of it is a certain degree of disability, a certain degree of weakness. I think physical therapy can do a lot. I think if you've never been to it, then yeah, you should go, because they can help retrain you in ways. They can help adapt. So it might be that you can't do it this way, but if you did it this way, you can still do the activity you love. You just won't be as fast, or you won't be doing, but you're still enjoying it, which is kind of the goal, is to keep you doing the things you want to do. Which is actually what I want to promote. What else we have here is we actually just hired a new occupational therapist to kind of do those things, the things that you actually want to do, that, people who used to garden, who tell me I would love to garden, I just can't do anymore. Why not? Let's try to figure out how we can get you to garden. People who tell me they want to cook again, I was like, I love food. How do we do that? So you got to find what it is that you really want to be doing, and then we got to figure out how do we get you to doing that. You might not be able to do it the way you used to do it, but I'm sure we can find some way to get it so that you're still kind of doing the same activity and still getting the therapy and the benefit out of it. Okay? All right.